Only a few items are required for basic airway management. These include a bag valve mask and an oropharyngeal or nasopharyngeal airway. Important components of a bag valve mask include a reservoir system that assures that each breath delivered is highly concentrated oxygen, a series of one-way valves that prevent the entrapment of room air during ventilation, and the bag itself, which is squeezed to deliver breaths to the patient. Note that when the bag is squeezed, the valves allow oxygen to flow from the device to the patient. Exhaled gases are prevented from re-entering the bag and are instead diverted through an exhalation port. The mask has three main components: a round connector that attaches to the bag, a hard shell that is usually clear to allow for constant visualization of the airway, and a circumferential air-filled collar, which provides an airtight seal when placed against the patient's face. Oral airways are firm, hollow tubes that, when inserted, provide a conduit between the mouth and the glottis. These devices have flanges on the proximal ends that prevent inward migration. Oral airways come in a variety of sizes. Correct size selection is covered later in this video. Nasal airways are flexible rubber or plastic tubes that provide a conduit between the nasal cavity and the glottis, thus preventing upper airway obstruction. Like oral airways, these devices come in a variety of sizes. In general, patients tolerate nasal airways better than oral airways. Nasal airways should be chosen in patients with clenched jaws or those who are semi-conscious and cannot tolerate an oral device. Nasal airways should not be used in patients with suspected basilar skull fractures due to concern of entering the cranial vault through a disrupted cribriform plate. The head tilt chin lift maneuver is a simple technique that can be used to relieve upper airway obstruction caused by oropharyngeal soft tissues. This maneuver requires movement of the neck and should not be used in patients with suspected or known cervical spine injuries. To perform the head tilt chin lift, use one hand to apply downwards pressure on the patient's forehead. Use the tips of the index and middle fingers of your other hand to lift the mandible at the midline and then gently extend the patient's head. This lifts the tongue away from the posterior pharynx and improves airway patency. The jaw thrust maneuver may also be used to open the airway. Unlike the head tilt chin lift method, extension of the neck is not required, and thus this technique is preferred in patients with cervical spine injuries. Stand at the head of the stretcher and place the heels of both hands on the temporal parietal areas of the patient's head. Next, grasp the angles of the mandible with your index and long fingers and displace the jaw anteriorly. This maneuver moves the tongue along with the mandible, thus relieving upper airway obstruction. Oropharyngeal airways are used to maintain airway patency and generally should be used whenever bag mask ventilation is required. First, determine the appropriate size oropharyngeal airway for the patient. When held against the side of the face, a correctly sized airway will extend from the lips to the angle of the mandible. This airway is too small since it does not fully reach the mandible and should be replaced with a larger device as shown here. Next, place the oropharyngeal airway into the mouth with the curved portion inverted, pointing in a cephalad direction. Rotate the airway 180 degrees as you advance it into the posterior oropharynx. The flange of the device should rest at the patient's lips. This technique prevents the airway from pushing the tongue backwards during insertion. Alternatively, you can use a tongue blade to depress the tongue inferiorly during the oropharyngeal airway insertion. As with a rotational method, use of a tongue blade prevents the airway from displacing the tongue posteriorly, which may cause further airway obstruction. Nasopharyngeal airways may be used instead of oral devices and are especially useful in patients with intact gag reflexes and signs of upper airway obstruction. First, determine the appropriate size nasopharyngeal airway for the patient. When held against the side of the face, a correctly sized airway will extend from the tip of the nose to the angle of the patient's mandible. Next, lubricate the nasopharyngeal airway with water-soluble lubricant or anesthetic jelly. Insert the airway along the floor of the nasal cavity. Use gentle yet firm pressure to pass the airway through the nasal cavity and under the inferior turbinate. Advance the airway straight back along the floor of the nasal canal until the flange is resting at the origin of the nares. The nasopharyngeal airway, just like its oropharyngeal counterpart, prevents the tongue from falling backwards and thus maintains an open airway. Using 2 nasopharyngeal airways, one in each nostril, may improve oxygenation and ventilation. If resistance is encountered, try rotating the airway slightly and re-advancing. If passage is still not possible, try to insert it in the other nares. Bag mask ventilation is a critical airway management skill, yet one of the most difficult to perform. Successful bag mask ventilation depends on 3 things: a patent airway, an adequate mask seal, and proper ventilation. Before performing any of the following bag mask techniques, an oropharyngeal or nasopharyngeal airway should be inserted. Hold the mask in your dominant hand. The web space between your thumb and index finger should be wrapped around the connector stem. Lower the mask onto the patient's face. First place the nasal portion of the mask over the patient's nose, and then lower the body over the patient's mouth. The bridge of the nose, the 2 malar eminences, and the mandibular alveolar ridge must be covered by the mask in order to achieve a proper seal. Avoid placing your hands or wrists or the mask cushion on the patient's eyes while making a seal. Doing so may cause a vagal reaction or ocular injury. Place your middle, ring, and little fingers along the underside of the patient's mandible and pull it upwards into the mask. This maneuver is analogous to the head tilt chin lift technique, and it further opens the airway. While these fingers maintain upward traction on the mandible, the thumb and index finger hold the mask tightly to the face and ensure a proper mask seal. If your hands are large enough, your little finger may be placed posterior to the mandible and perform a jaw thrust maneuver to provide further airway opening. Pull up only on the bony parts of the mandible. Pressure to the soft tissues of the neck may occlude the airway. Once a good seal has been achieved, begin to ventilate the patient. In most cases, the ventilatory rate should not exceed 10 to 12 breaths per minute. Use a tidal volume just large enough to cause the chest to rise. 2-person bag mask ventilation is more effective than the single-person method and should be utilized if possible. In this technique, one clinician is responsible for maintaining a proper mask seal, while a second clinician squeezes the bag to provide ventilation. The more experienced clinician should handle the mask, since it is the most difficult aspect of this procedure. The first provider holds the mask in his hands in a fashion similar to the 1-person technique. The web spaces between the thumbs and the index fingers are placed adjacent to the connector stem, and then the mask is lowered onto the patient's face, nasal portion first. The middle, ring, and little fingers are placed along the underside of the mandible and pull the jaw anteriorly. The thumbs and index fingers hold pressure along the superior and inferior portions of the mask. Once a proper seal is achieved, the second provider attaches the bag to the mask and begins ventilation. Note that the first clinician may provide a head tilt and a jaw thrust maneuver while holding the mask onto the patient's face. Observe for proper chest rise during ventilations. An alternative method, using the stronger thenar eminences to hold the mask to the face, may be used if desired. The first provider holds his thenar eminences parallel to each other along the lateral edges of the mask. The mask is then lowered onto the face, and the fingers are placed along the underside of the mandible. Pressure is applied to the mask with the thenar eminences, while the fingers pull the mandible upwards. Chin lift and jaw thrust may be applied concurrently. This technique is easier to perform, allows stronger hand muscles to maintain a proper seal, minimizes fatigue, and enables 4 fingers to perform chin lift and jaw thrust.